So now I'd love to introduce Dr. Shannon La Cava. She's the Chief Clinical Officer and Director of Programs at the Cancer Support Community in Los Angeles, where she supervises a clinical team of licensed clinicians and graduate student trainees, stewards hospital and community-based organization partnerships, and champions a professional advisory board and diversity and inclusion committee. Dr. La Cava actively participates in the American Psychosocial Oncology Society, APOS, and is the current chair-elect of the American Psychological Association Health Equity Committee. Her research interests focus on multidisciplinary engagement to address health inequities and support the psychosocial needs of pediatric, young adult, and adult cancer patients and caregivers. So please welcome Dr. La Cava.
Thank you, Myra. I'm really excited to be here. I'm excited to have this summit, and I also want to give our gratitude to Natalie for that incredible talk, so thank you. So I'll go ahead and get my slides ready here. So today's talk is going to be Achieving Equity in Cancer Care Through Community Collaboration. I have no financial disclosures. So who am I and why am I talking to you today? So a little bit about my perspective. This is the on-paper piece about me. I'm trained in clinical psychology. I consider myself an integrative psychologist. As Myra said, I have a focus in psychosocial oncology and participate at APOS. And I'm very privileged to say that I'm a chair-elect for the Health Equity Committee at the American Psychological Association. I was able to join that committee this past year to really bring in that focus of cancer and oncology care. So what's not on paper about me? And I think this is a bit more the driving force of why I'm here today. That is experience before going back to school. I had a slow route to graduate school. I had experiences volunteering, both at retirement and aging living situations, also in child life at the Children's Memorial Hospital in Chicago. I worked at a nonprofit in Chicago called St. Vincent de Paul with the mission of ending poverty and violence in the city of Chicago. And those, along with a personal experience of having cancer in my family, were really those forces to where I got today. So these experiences shaped me, shaped my work to actually work now in a nonprofit sector, as well as engage at a greater level with the community that I work in. So the objectives for today's presentation, it's to define health equity and identify ways and frameworks and models of care with regard to health equity, to identify tools for health equity self-assessment, and to list values of partnering with multidisciplinary teams and other community-based organizations. And the way that we're going to do that is look through these different areas. We're going to focus on social determinants of health and health equity, public and population health, community engagement. We'll focus then on cancer and our work here at CSCLA, and then I'll invite all of you for engagement. So social determinants of health and health equity. Focusing first on social determinants of health, this is what we often hear of where people were born, where we live, work, play, worship, age. It's the environment around us. And this particular diagram here comes from Healthy People 2030. I've also seen pie charts and different frameworks of social determinants of health that come with 6 or 11 or 12 areas, but this is 5 areas of social determinants that I really want to focus on. Healthcare, and that includes the access and quality of care, is one that we'll focus on for the majority of our talk. But there's also education and access to quality education, economic stability, the neighborhood, the environment that's built around us, as well as social and community context. So what is health equity? And we spoke a little bit about this. Natalie gave us some incredible illustrations of equity. This is the definition from Robert Wood Johnson Foundation. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness, lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And I wanted to read that verbatim. I think this is an excellent definition. But we can go on from there, though, to talk more about those that are in healthcare and the responsibility that we have because there's no accountability without measurement. So this goes on to just really consider the fact that we would want to make change, and that will be our primary focus. So some suggested actions in healthcare. So these are different ways that we have some control. And that's even in screening. If we're going to utilize screening, adopting vital signs for non-medical factors. This might look like distress screening that's in place at many hospitals. We have that here at our community and through our network of cancer support community to really ask questions about the impact that for us, it's cancer. But what is the impact on that person in terms of that medical diagnosis? So it's looking at those non-medical factors. Other areas are to commit to non-English speaking patients. This can be programmatically, this can be in research. Guarding against bias, so just being educated. Julie, at the very beginning of our event today, really talked about how we're learning too, and there's going to be constant learning, I think, for all of us. Clinical trials is another way to look at that. Are we representing racial and ethnic minorities? Are we representing women? Are we representing across the age from developmental to older adult? And then last year is understanding effects of adverse childhood experience or traumatic history. And I'll give an example here. Mount Sinai had an incredible educational program, I think put through NIH, but on sensitive practice training, which is guidelines to working and treating adult survivors of sexual violence. So those are other ways that we can engage and learn. So this is a framework that's put together by the Robert Wood Johnson Foundation with their work with RAND, and it incorporated about 1,000 experts and community members to develop this framework. And it really focuses on making health a shared value, fostering cross-sector collaboration, which we'll go more into, creating healthier and more equitable communities, and strengthening the integration of health services and systems, with the ideal outcome being improving population health. So I do want to say that there's research indicating that building relationships among partners is sometimes the most challenging aspect of creating change. And to give an example of that, we work in a fabulous network of cancer support communities and Gilda Scrubs across the country, even international. We have 4 right here in our backyard, and we're just now really considering what does it mean to partner, what does it mean to collaborate and do so in a meaningful way. So collaboration can look like interdisciplinary or multidisciplinary partnerships within sectors, outside of your sectors, like crossing traditional boundaries. One might look like hospitals collaborating with community-based organizations. So it's thinking a little differently. This is just a list of some health equity impact assessment tools. There's many out there, and actually APA is in the design phase to put something together here. But this is to find a way to kind of look at how we are engaging. This can be programmatically, this can be through research, this can be just through partnership. Areas of different assessments that you can do to kind of just take a look at your own work is how are you establishing your parameters? How are you involving the community? How are you creating an assessment plan? Other areas are how are you looking at dissemination after you provide research or after you do a program evaluation? How are you monitoring the program? So there's a lot of different steps, and I would say these are a wonderful way to just kind of take a look, a little internal look to how the work that you're doing impacts equity and also how you're working collaboratively. So public and population health. So public health, to talk a little bit about this, there's a couple different definitions here from CDC and some information from Medicaid, but overall, it's really the science of protecting the safety and improving the health of communities. It goes on to even say at the community to the global level. So really focusing on entire populations. Population health, if we were going to dive down a little bit into that population health area, it's a science of analyzing the inputs and outputs of the overall health and well-being of a population and the use of this knowledge to produce desirable population outcomes. So you hear me talk about like inputs and outputs. So the inputs, that's a lot of those social determinants of health. This is the policies that are in place, genetics, behaviors like smoking, like diet, treatment adherence. There's also social factors that would be kind of, if you look back to the idea that we had in that pie chart about different areas of public health: employment, education, poverty levels, and environmental factors, occupation, water safety. These all come into play. And then additionally, the population health is a framework, and it's designed to align components of the health system. So this will be inclusive of integrating the care delivery system with the broader health and social system. So it's the idea of that collaboration. So how do they fit together, public and population health? So if you look here, this is a framework. This is the triple aim framework of public health. And within this framework is population health. So population health is a goal of public health. Organizations and professionals that carry out the work of population health, they do so by assessing community needs, designing, implementing, and evaluating programs that may work to prevent or educate about disease, work to reduce health disparities, make recommendations or standards of care, establishing best practices. So all of these are within that scope of public health, and ultimately providing resources to the community to carry out efforts. So said another way, you can consider population health framework as an expansion of the public health agenda, and with the ultimate goal for this greater collaboration and collaboration for the greater good. Success depends on how entities of healthcare, so this is the payers, the providers, the public health agencies, community-based organizations, businesses, those that make policy, all of this together depends on how they work together to adopt the framework and collaborate with one another. So this is coming out of the CDC, and this is a list of public health services, 10 essential public health services. And I would say ultimately here, this is a framework to protect and promote the health of all people in all communities. Pulled out here the fourth point of strengthen and support communities and partnerships to improve health. So we will look at that. And the overall goal is to enable optimal health for all. If you think back to that Robert Wood Johnson Foundation definition that we had of health equity, it's really about the better health, that everyone has the right to being healthy and living the best life. Another goal here, though, would also be to remove systemic and structural barriers that have resulted in health inequities. And Natalie really kind of highlighted a lot of that. So this will include poverty, racism, gender discrimination, and other forms of oppression. So public health would really want to reduce those barriers and ultimately eliminate those barriers. Ultimate goal being everyone should have a fair and just opportunity to achieve optimal health and well-being. So this is an illustration to just look a little bit at the history of public health. So in the late 19th century and much through the 20th century, the focus was more on sanitation, food and water safety, development of medicine and prevention. It moved then into the second half of the 20th century into this public health 2.0 idea. And really a lot of that would be the focus on the AIDS epidemic and what came out of that and what we learned from that. So in 1988, the Institute of Medicine, which is now called the National Academy of Medicine, by the way, but they came out with the future of public health. And in that report, they said that public health authorities were encumbered by the demands of providing safety net clinical care, and they were unprepared to address the rising burden of chronic disease, one being the AIDS and HIV epidemic. This was a new threat. And ultimately, at this point, the IOM declared that the nation has lost sight of its public health goals and has allowed the system of public health activities to fall into disarray. So Public Health 2.0 really built on that. Corrective actions were made, performance standards were put in place, and agencies were put in place across every level. So then that brings us to 3.0, which is really around the time frame of 2016. And this is where the vision of cross-sectoral collaboration really comes into play. To dive down a little bit into here, we'll look at these recommendations that came out of Public Health 3.0, leadership, strategic partnership, infrastructure, accreditation, data, and sustainable flexible funding. Looking a little deeper into strategic partnership, you can see here that the NIH, the National Institute of Health, really puts focus on continuing community-based participatory research. So working with the community when creating research projects. Healthcare providers should identify mechanisms to collaborate with local public health and share their goals together. Public health leaders can utilize local partnerships to ensure population health is a primary focus. So how do we do all that? So let's talk about how we can do some of this work through community engagement. So a little bit more about community-based participatory research. So this is a style of research where the partnership approach is to enable the researchers and the community stakeholders to engage together as equal partners across all aspects of the research process. What I would say this looks like is, rather than a scientist or a researcher or someone with a lab coat that might be a little bit distant from the community, coming up with the questions and the projects that they're going to really look deeper in. Instead, they're engaging at the grassroots community level and seeing what the issues are at that stage, seeing what questions the community has, and then working with the community to develop this project. To give some illustration here, it's about forming a partnership in those elements about assessing the community's strengths, identifying the public health issues, conducting the research together, finding ways to give feedback and interpret research with the community. So that's the dissemination as well. And then final dissemination and translation of research findings. All throughout this, a major focus of community-based participatory research is to maintain, sustain, and evaluate the partnership itself. So there is a lot of focus on how that engagement, how that partnership and collaboration is really working, aside from just the project that they're working on. So a little to focus on service delivery, and this is coming out of the Association of American Medical Colleges. One of the areas of mission there is community collaboration, really to show that partnerships designed to share expertise and resources with communities through trustful, mutual respect, cultural humility, relationships that really focus on those areas of trust. And include the community-based service learning, include the community engaged research. Those together are the most successful ways to partner and to move forward in this community collaboration. Coming out of the Association of American Medical Colleges, just this year is the Center for Health Justice, and I have a link here, and we will share the slides, I think, eventually on our website, so be on the lookout for that. But I will tell you what they've been up to, because it's been some incredible work coming out this year from the AAMC. But overall, with this mission of community collaboration, they have medical schools and teaching hospitals working together to ensure the health of all by collaborating with communities across clinical research and education missions. And I wanted to share that piece because I think it really highlights that need for a partnership. And then that component that's coming out of their Health Justice Center, this is a list of principles of trustworthiness. So this was developed through community engagement and interview. And they have videos on their website actually that are just really incredible. And one of they have even is about vaccine hesitancy. So if you do get an opportunity to check out those videos, they're wonderful. I was struck by some of this coming out of the work that it doesn't start or end with community advisory board. It's not checking the boxes, it's doing the work. So if you read through these, I hope some strike you too as ways to be like, how can we work together? How can we do more? And how can we honor what is existing in the community? Natalie also talked about that they already are educated, right? That's the first point here. They already know what they know, and that's what we might want to learn, not come in with the assumption that we need to teach. So another piece here is that the project might be over, but the work is not. So each of these areas I think are really great, and they kind of value the community perspective and influence the engagement of the relationship, really looking to the point of building trust. So this is coming from Missioner, and he did a paper with his colleagues on steps that public health can take to engage with communities and partners for sustained changes. And this is all through the age of COVID-19. So it's the intersection of community collaboration and COVID-19. And these are recommended steps here of how to engage. Specifically, those areas of partnership and working collectively and sharing, I just want to focus a little on talking about gathering and sharing and interpreting data with community members and leaders, assessing risks together, ensuring equitable access, collectively working to design and implement a priority, with priority being placed on equity, and co-creating. So a lot of the same language, we're using synonyms here. We're talking about how we work with one another. In terms of sharing, how we gather and distribute stories of data, participate in learning collaborative. I will say in terms of COVID-19, we had to pivot very quickly, our organization and our sister organizations. We had our online programming up on March 16th of last year, which was that first Monday after it seems like everything shut down. And what we learned, we were able to share across our network, and we continually learn from our network. So it's really about sharing strengths and challenges. So for the article here, lessons learned from COVID-19, COVID-19 exacerbated what was already there. It deepened inequities. It deepened the racial discrimination at a structural and systems level. The lessons might be learned from COVID-19 that partnerships really were the cornerstone of public health efforts and ways to give support to those that were having medical and then social justice components of this syndemic, I'm hearing, of what we went through in 2020 and continues to go through. In terms of the response, it was really about partnerships with a history of collaboration. We're able to rapidly respond to immediate and critical needs of the community. So those communities where there was already collaborations, where there were already partnerships, those were able to respond more quickly to the pandemic. What that means is community engagement. It was critical in the AIDS epidemic, if you recall the disarray of public health in the 1980s, but we've learned from that. And activists can raise awareness as they did back when the AIDS epidemic started. We're seeing that now. Community-based organizations in racial, ethnic, and sexual communities played a critical role in the HIV prevention efforts, and that continued on. So where those partnerships were already created, that is where there was a lot more success in a response to COVID-19 pandemic. So basically, the rapid response became more evident where there was history of partnership. To go a little into detail there, partnerships utilized the health equity framework, partnerships that engage with the community and recognize the community's strengths, those that were driven by data and those that built trust. Each of these partnerships were far more effective during COVID-19, or especially in the more immediate response during COVID-19. Overall showing that community partnerships are critical elements of public health and can be built through intentional, stepwise engagement with marginalized communities and wider partners. So bringing in the element of cancer. So this is just a few of the real seminal reports on that have to do with psychosocial oncology or cancer care and really considering the whole person, as well as standards in place for accreditation for hospitals that have comprehensive cancer centers. We have here the Institute of Medicine 2008, Cancer Care for the Whole Patient, Meeting Psychosocial Health Needs, as well as 3 iterations coming out of the American College of Surgeons, and I'll go into detail. For cancer care for the whole patient, the Institute of Medicine was asked by NIH to form a committee with the goal of assessing the delivery of psychosocial services that cancer patients and their families need. And what came out of that was cancer care for the whole patient, and they recognized that psychosocial health problems are common and often undertreated. This is a list of some of the areas: physical stressors, limitations of ADLs, psychosocial problems, social problems, insufficient resources, and obstacles to managing psychosocial stressors. If you will, there was also information here that there were existing resources. So back to that understanding the value of the community and not coming in with not building trust and not understanding what's in the community. There were many resources, and they continue to be many community resources, and there continues to be need, but the bridge is what was missing. And this was what was really evident here in 2008. So how do we get the community that has the need for support to the resources that are existing? How do we build that bridge? And then the 3 American College of Surgeons standards in 2012 was the first ensuring patient-centered care. It had a reiteration in 2016. And then in 2020, the standards came out called Optimal Resources for Cancer Care. There were 2 updates this year, and those will be in effect on January 1st. So to look at what that means, these are just a few of the standards out of American College of Surgeons, and these are for accreditation purposes. There's approximately about 1,500 Commission on Cancer accredited cancer programs in the US and Puerto Rico. And the accreditation encourages that hospital, treatment centers, other facilities improve their quality of care through various cancer-related programs and activities. Standards here speak to survivorship programs, palliative care services in terms of expectations and protocols, that psychosocial distress screening be put into play. We spoke about that briefly. And that cancer prevention events be implemented. And this is for professional and community outreach. In addition, it really illustrates that psychosocial services can be available on site or by referral. And further, it's recommended but not required that cancer committees partner with community organizations to hold cancer prevention and educational events. So one more way of saying that collaboration is a way to meet these goals. So let's talk about CSCLA for a little bit. Okay, so this is a bigger diagram, and this is coming out of our headquarters. So Cancer Support Community and Gilda's Club, we've been in existence all the way back to 1982, when actually the wellness community was started right here in Santa Monica, to 40 years later, celebrating our 40th anniversary next year. And what's come out of that collaboration and this greater network is these 3 different areas of targeted purposeful work. So we have a research and training institute that really kind of provides the evidence for the work that we do, and we share that beyond. We have a policy institute where we can actually go beyond just our network into federal policy and make change at the federal level and really support cancer patients and families to advocate for themselves as well. And then direct services, and that's a little bit where I come in. So that's at the affiliate level, where we're on the ground and giving supportive services to families impacted by cancer. This is a list of all of the centers that we have across the country and worldwide, with some in development. And then just to illustrate the collaboration of our local level. So again, there's 4 around the Los Angeles area and the greater Southern California area. We have CSC in Los Angeles, Pasadena, and Redondo Beach, and then one in Westlake Village that services the Valley, Ventura, and Santa Barbara. So we're working together collaboratively because there's overlap. And how can we make sure that no one that is in the Southern California area that is going through a diagnosis of cancer themselves or in their family, that they don't fall through the gaps? How do we build that bridge? So at our location here in Los Angeles, and Julia made a wonderful introduction to our committee members, but we've developed a Cancer Equity and Diversity Committee. And there's purpose to the language. We call it SED because in Spanish, the pronunciation SED means thirst. And we've really utilized that in the way we've developed this, that the committee was created to fill the thirst of the community members striving for multi-directional inclusion. So again, we're not going into the communities and just bringing our existing programs, our existing services, and our knowledge. We are partnering with the communities, and we are absorbing from the community what they can share with us, what the trust that they can build, the information and education that they already have. How can we build that to make sure that the needs, the actual needs of the community, are what we are delivering services for? Additionally, we have a professional advisory board, and this is made up of multidisciplinary leaders in oncology and supportive care, integrative care across LA. So this is how we really kind of are able to soak up outside of ourselves information and knowledge to do better work. Coming out of that is our way to engage, the voice that we spoke about from the SED community, really paved the way for us to really look at how we can target and put together programs that matter and are meaningful to the community around us. We have programs for children and teens, the LGBTQ community through collaboration, the Black African American community. We have a villager support group and educational presentations. We have Spanish speaking programs and more for just the Latinx community. We are developing programs for the Korean community by bringing services that fit their needs. We're not putting a support group, we have it listed here, but more of a social and then time to engage and have coffee and talk to one another and build trust. Additionally, we're coming up with services for the young adult population because there's fewer young adults with cancer and their needs are different. So how can we meet those needs? Existing partnerships that we have, we're considering this our heart initiative. Many of these relationships we've had for some time, but we put a name to it, and that's healing equitably through action, resilience, and teamwork, because it really is a collaborative approach. So we have partnerships with Adventist Health, White Memorial, the American Institute of Cancer Research. We've done education with Cedars-Sinai, Angeles Plaza, again, the LA LGBT Center. We've done work with Pediatric Brain Tumor Foundation, Providence St. John's Health Center, and Village Health Foundation. And there's others that haven't been listed and that we're in communication with. So we are constantly striving to work more with the community and see how we can offer our services farther, greater, and beyond just where our main location is here in West LA. So what does that mean? So this now is where we talk a little bit about the opportunity to engage. So community partnerships, like we said, I think are so valuable, and different styles of community partnership can be within and across disciplines, interdepartmental or cross-sector, big or small, multi-institution, community-based, and I definitely have some connection with the community-based work. So we invite you to partner with one another, with us, and just even get out there and see how you can engage and work together. Think outside of the box. So together, through a lens of health equity, we can collaboratively engage with communities to revolutionize supportive care for families facing cancer and provide inclusive and targeted support while enhancing value across the healthcare system. So with that, I want to thank you. I will welcome questions, and I will stop my video here. I will show, though, I do have references, and these will be available for any of you when you need them.
Thank you, Dr. La Cava. That was a wonderful presentation, and thank you for taking us through, that evolution of public health and giving us a little bit more information of the social determinants. And I know you ended with talking about building those community partnerships. So, my question to you is, how do we work with those communities that are very hard to reach? And so how do we bring those to the table? Do you have any suggestions for those of us who are trying to do that work?
Yeah, I would say time and investment, and it's really to the point of stewarding. And I think you even said that, I had it somewhere written in my bio, maybe. It's stewarding relationships. It's not necessarily going right in and, in terms of sales where you'd make a cold call or you would just put an email out there. It's kind of, how do you network? How do you find somebody that is, understands and champions the work that we do, and how can they make an introduction, and how can we build trust in the community? So some of those areas that are harder to reach, it does take a little bit of time, but it's with always that idea of investment in the community and being available to the community, I would say. To add to that, also the idea of not thinking that what we do will fit, and not expecting what we already do to fit. We have a long history of philosophy here at CSCLA that's incredible. It's the foundation to all that we've done. But what's working here in West Los Angeles might not be the same thing that works in another community. And I think that's where the humility comes in. That's where we need to be humble. We need to learn what the needs are. I spoke a little bit about the Korean group And we originally started to do something in terms of support, and we realized what we need to do is just build trust. So actually tomorrow we'll be at Angeles Plaza having a community engagement event. It's a social coffee and treats, but our Korean speaking licensed clinician will be there to really just begin that conversation, to introduce herself, to talk about what she does, and who she is, and build trust. And then we'll see what the needs are and if there's something that we can build collaboratively together. I think the biggest thing is the word with. How can we build with the community?
And that actually is a good segue to the next question that came in, because you talked about how all the community, it's different. So somebody asked, how do you effectively collaborate across a huge landscape like Los Angeles?
So I think I can learn from these talks as well. I would say to be effective with the collaboration. And honesty too. I mean, we are a nonprofit. There are, I think, 7 or 8 of us usually working together on the administrative side. So we wear a lot of hats and we do a lot of work, but always with that lens of engaging and getting out to the community. We don't have an advertising or marketing budget, but do you know what we have? We have some incredible community partners that when we share what we have, they'll share it with their larger network and vice versa. We've recognized that we're not doing it alone. So as we find these amazing partners and champions in the community, we'll share their information. Do they have a screening? Is there a van going out that the community can go to for, education around healthcare or preventative medicine? We will make sure that we put that out as well. So I would say that's one way to start, to just even get some recognition in the greater community. And then from there, gain trust and build upon it. But it takes time.
Yes, definitely takes time and effort. Now, our next question is, what type of outreach has Cancer Support Community Los Angeles done for Asian American community, especially during the pandemic when there's extra stressors for the AAPI community?
Yeah, that's a good question. So in terms of the work that we're doing for the specific community, like I said, we right now we've brought on staff that is Korean speaking, and we're trying to do something there. But we also have staff that are sensitive. We have sensitive practice trainings within the staff, so we address those needs. We utilize a lot of supervision and case consultation for all of our clinical staff, so we can discuss together how to support and come from that sensitive lens with all of our support groups, and making space for that kind of a dialogue in any of the groups that we have, even if it's not targeted to any particular population. We're able to welcome and hold a safe space for some of those conversations.
Wonderful. Now, our next question is, how is the Cancer Support Community in Los Angeles culturally sensitive in its outreach?
So I would say the way that we would utilize cultural sensitivity is, again, understanding that we don't want to just hang a shingle on the door and say, okay, now we have a support group here, come. It might not be the need. It might not be what somebody wants in a community. So we will cater to and change and modify. I think I use the word pivot so many times at the very beginning of COVID. It's like, okay, so we've learned how to be flexible. And I think we've modeled that to all of our staff and to our greater community. And that is a way that we can go into a community with that sensitivity, but also humility and knowing I might not know what's best. So for me, the idea of being culturally sensitive as I go into the community is finding somebody within the community that can join our staff. We are not just picking people that are existing and moving into a greater location. We want to actually engage those that might be licensed clinicians throughout Los Angeles. Would they like to come on board? How can we partner with organizations that have a really great focus to do work within specialty areas, with special communities, with just a special focus that's more defined than our own? We're coming from the lens of cancer. So being able to partner and have somebody represent and learn what we do as we learn from them how to engage with the community. I would say that's one way that we go sensitively into the communities.
Yeah, that's wonderful tips. Our next question is asking, are there barriers for care in underserved communities to Zoom meetings? And do we know if some communities prefer face-to-face meetings?
So barriers to care, that's a great question. And so what I'm hearing a lot of is the digital divide, and we're very aware of that. We've even written grants to see if we can get some funding to cover the cost of a hotspot and some tech. So while we are all online, we know there's people that cannot access our services, and that either because they have a house full of kids and during 2020, everybody was online, the internet's not strong enough, there might not be as comfortable with the technology, and sometimes they just don't have it available. So understanding there's a digital divide, I know we have more to do to make sure that we can build that bridge to be able to provide that, but also just the desire. Yes, when we went online, I think it was a very big switch for those that were in person to join an online support group. Education came a little bit easier. Social did not really fit. There really wasn't as much of an interest for some of our social programming. But in time, things have changed, and we've had a lot of individuals that have joined since we went online, since COVID started. So that's kind of their really first experience with support groups. So yes, we do get a lot of individuals saying that they're ready to be back in person. I know that. I know I'm ready to see everyone in person again too. But we did a program evaluation in September of 2020 and again this year. And it was really surprising to see the interest of those that were really liking this online model. I think potentially liking it to be hybrid where they can choose to be in person or online. But there is a value that I want to talk about just briefly with our online services. We had people reaching out that had not ever been able to come to our services due to treatment. They might have been bedridden. It might have been a challenge to get here due to geography. LA is big, transportation is expensive. So we suddenly had this influx of individuals that did not have access before. So ultimately, I think our goal would be for 2022, having in-person services available, having an online program as well, so that we can really try to make those connections as far and wide as we can. And again, through collaboration, having satellite locations where we can have in-person services, but people don't have to come all the way here to West LA.
I think that's wonderful. And many of our organizations are probably going to move to that hybrid option, right? Because you're absolutely right. There's the digital divide where we don't want to leave some people behind and be able to offer those in-person services. But you're right, with offering those virtual sessions, we are able to reach some populations that we couldn't reach before. So thank you for sharing that. Our next question is, how do you prioritize the wide range of needs in your diverse community with limited resources?
Oh, such a good question. I talked about hats, right? So I think I'm fortunate. I work with the most incredible staff. Everyone is just on board and ready to go all the time, taking on projects and really stretching and challenging themselves. And it's been incredible. I would say not to just think of potential burnout. We really also kind of honor that we have a staff where it's important to take time, and self-care is important. Being online is a different type of fatigue, so we make sure that we look at that as well. But having individuals that really can wear a lot of hats and put their efforts into different areas and challenge themselves with new areas, that's, I think, how we're able to do this greater work with the limited resources that we have. Financially, we are a nonprofit, but that, I think, is the catalyst to pushing us to engage with other nonprofits. Again, working in silos, I think, is where we'd be the most limited and we would have the least amount of services. But as we work with our other sister organizations in Southern California, with other nonprofits that have a focus with cancer, or with other organizations that are outside of cancer, but work with populations that have needs. So that, I would say, is how we kind of can have those concentric circles of growth and engagement across the country. For us, LA, I feel like it's across the country sometimes because it's incredible the amount of interest that we had for this talk today. But that is how we can build those circles with limit. We're only one person, each of us, but how can we work together because we get a much greater reach?
Right. Those of us, we become resourceful, right? I mean, you have to be, when it's limited in resources. But I definitely agree that, the partnerships are key, leveraging those resources when you work collaboratively and overcome those silos. It really does make a difference when all of us are working with limited resources. If you come together, you're able to create these programs or create projects and create resources that you wouldn't be able to create otherwise. So thank you for sharing that. Now, our next question is, what can mental health clinicians do in their day-to-day practice to promote equity in their work?
Such a good question. And I'll have some ideas here, but I think this is an area where I'm learning. I think we're all learning and we're all making improvements. So I would say just that question, having the, I guess just the strength to put the question out there. I think that's starting the conversation. And I really want to look back to Natalie and how much she really just introduced the idea of let's just start talking and let's start working towards this equitably. Natalie actually put out, I just pulled it up on my phone because she did a QR code about the Foundations of Equity, Diversity, and Inclusion online course. We can start there. We can start learning. There's information. Attending today. We're going to have incredible talks today. So these are just ways that we can absorb how to be more equitable in the work that we do, how to identify where there are inequities, how we can identify strategies to make change. Some of the programs that I've gone to, like I said, coming out of Mount Sinai was sensitive practice training. So I'm going to incorporate that into my work. Other ways to look at how we work are we able to potentially look at other languages? And I'll say a gap for us. I wish this was in more languages, but this is our inaugural event. We're going to learn from this, and we have great goals to make sure that we can deliver this farther and wider. So I think just looking kind of almost intrinsic to yourself, but into your practice and into your institution, those assessments, there's the health equity assessment tool. Those are ways to start asking those questions. How are you engaging? How are you partnering? And how are you utilizing what you've learned? How are you utilizing research to go forward in that work? I think there's a few ways that we can start.
Yeah, thank you so much for that. Our next question is, what has the cancer support community in Los Angeles done during the pandemic to meet the needs of individuals with technology barriers?
So I wish I could say that we've done more, but we have implemented as much as we can on phone. We've put some grants together, not all successful, but we were working on that to kind of work with that digital divide component. But something that we have done is really kind of following the needs. I can mention a little bit at the early stage of COVID-19, we had two well-attended groups in Spanish that were at White Memorial Hospital. And so we pivoted those, but online was not the place for those. So we tried to do phone check-ins. We made it so there was at least some contact. Understanding the level of isolation with the cancer diagnosis it's one of the highest things that can be measured when we're looking at distress. And then COVID just really put isolation, for everybody. And it just exacerbated that existing isolation for someone living with cancer. So we understood that, and we wanted to make as much of a connection as we could. We also recognized where there was other technology problems in terms of getting connected. A lot of these platforms, much like we're on today, platforms that are used for video or phone, a lot of times if you're calling in from the mainland United States, the outgoing message or prompts, they're only in English. So we recognize these different challenges and really tried to work around them as much as we could. But then changes also made. We've seen that in improvements in technology. And our group currently is online because we did a lot of teaching and education around it for those that were able to use smartphones, and we thought differently about getting connected. And actually the feedback was pretty incredible because they didn't, from this one group that I'm thinking of, talking about seeing somebody made such a difference, like not knowing that the strength of that, or seeing someone they hadn't seen in a few months. So, but I think it would be incredible to identify additional opportunities. And I think that's where that partnership and collaboration comes into play. Grant writing aside, because that's one level of really connecting financially, but how can we work together with agencies where if there's some agency or organization that can deliver a service and another that can really identify the platform, and then make it accessible to all. That's one way that I think would be a really amazing partnership.
Yes, yes, it definitely would be. Our next question is, have you been able to measure the impact of providing access to support for underserved communities, the true value in reductions in anxiety or depression, and improved care or access to healthcare?
Yes, I would say we utilize a distress screening here at the Cancer Support Community in Los Angeles, and I think across our organization. And we're able to check in with somebody at that point of engagement. And again, asking those non-medical questions of how they are doing in terms of this diagnosis for themselves or within their family. And with that, we can track areas of distress. I mentioned isolation, but additionally, areas of depression and anxiety, we can keep that in mind, and we can rescreen after somebody's engaged to see where that level might be. We utilize this also with individual counseling. So we're able to really kind of assess where somebody is and then see where they are at the end of a program or at the end of their individual care. So that's a wonderful way that we've been able to see these measurements. And that influences also how we engage with the community. What resources do we need to make sure we have available? Who should we partner with to make sure that some of these other resources are available? I'll say in terms of resource sharing to meet these needs, I was invited onto a couple different committees and advisory boards through different hospitals and agencies around LA. And that alone is wonderful, and that trust for the invitation, but meeting everyone else that's sitting around the table that also was invited, that is what's incredible, because all of a sudden now I know somebody who has breast cancer screening and a tool available into the community to get access to financial aid. So I can share that and promote that. So we not only we have the screening and we can do measurements, but then we also can connect with services and resources.
Yeah, wonderful. Our next question is, what are some of the challenges of collaboration?
Well, I think I mentioned that there is research to show that the collaboration can be one of the trickiest elements of that partnership piece. I would say challenges with collaboration, it's timing. I don't think I'm saying anything new to many of those that are on the call today, that sometimes there's not enough hours in the day, and sometimes there's a lot of responsibilities, and we pivot when we need to and do something that might not be exactly in our job description, but we know we're the person to get that done. So I would say challenges is just making sure that we engage at a regular basis. My recommendations for that would be anytime there is a meeting or a connection or some point of contact, that there's a plan for what's next, or a plan of action for anybody that's, what are the responsibilities coming out of that meeting. So really that level of engagement. And as I talked a little bit about community-based participatory research, the thing that I thought was just kind of really amazing about that style is the way that the partnership itself is under the microscope, making sure that all of the potential challenges, all of the ideas of how do we want to communicate, that is identified on the front end. Expectations are set. And I think that's a great way to see how we can use that same idea in terms of all of our engagements across the sector and internally.
Definitely. Thank you so much. Now, Dr. La Cava, you mentioned earlier that one of the best ways for you to meet the needs of the community was to have staff that's representative of that community. I know that a lot of us organizations, want to be able to include staff that looks like the community that we're serving, that is from the community that they're serving, so that they're better able to relate and understand those needs. What efforts has the cancer support community done in order to hire staff that's representative of the community that they serve?
Yes, so the majority of that is currently in our clinical side. So looking to bring some staffing in. I was actually just talking with somebody this week, but how do we bring someone in, not just to fill a position that already exists for us, but how do we think differently about how we can partner to offer services? So how do we work with another organization that has skills or has locations that does mental health services, and work together to get education to their staff about cancer and psychosocial oncology care, to get to the greater community. So I think it's thinking differently. We are absolutely looking to bring in staff and find more funding. It does definitely come down to that piece of, we have grant writers on staff that we didn't have in the past. We're thinking differently about where we're wanting to expand our services, what funders we're looking to get these grant applications into, and each of those really targeted to then also build our staff to represent the communities that we're in. And the champions that we have, we mentioned the Cancer Equity and Diversity Committee, that is a guiding force. So I think, you know, that idea of networking and meeting one another that have common goals versus working in a silo has really supported that. You know, meeting somebody that we've known for a long time and has been a champion of CSCLA, who introduces us to a postdoc that they work with that has interest in cancer and may have be bilingual or multilingual, and so how okay, let's talk together. What are your interests? How can we work together? And I think following the strengths and interests of our staff is another way to do that, even to the administrative side. Where are the interests that you have, and how can we feed that and fuel that? And that also, I think, assists in getting out into the community.
Well, thank you so much, Dr. La Cava. That was a lot of wonderful information and tips that I know I will definitely use in the work that we do.